thank you for joining us for today's webinar. My name is Dr. Savannah Clary, and I'm part of the clinical team here at Aegis. It is my pleasure to present briefly today regarding the topic of responding to the unexpected, harm reduction, and improved outcomes. It was hard to condense this into a brief webinar for today, as this is a topic that I could spend a lot of time talking about how medication monitoring as part of a holistic monitoring protocol can help with harm reduction and improved outcomes. But I hope the overview that's shared today will be helpful for you in thinking about how the information that can be learned from unexpected results, how this can impact a monitoring protocol. Before we get into the details of the topic, let me clearly state that this webinar is for informational purposes only. It's not intended to replace or supersede a clinician's judgment or the assessment of the individuals in their care. The ultimate decision of who, when, and how to test individuals for appropriate and inappropriate drug use remains at the sole clinical judgment of the provider. Multiple activities can support harm reduction efforts, and these activities may all be appropriate, including but not limited to review of the state prescription monitoring database, if available, pill counts, treatment agreements, practitioner evaluation and documentation of aberrant behavior, individualized counseling and education on the risks of chronic opioid therapy and possible drug and substance interactions, prescribing naloxone, and any other treatments, interventions, assessments, or clinical care activities deemed necessary by a practitioner or recommended or required by payers or regulatory bodies. Our objectives for today are to identify examples of unexpected toxicology findings and possible interpretations, review risk assessment tools and how unexpected toxicology findings could inform risk assessment, discuss possible next steps after receiving unexpected results, incorporating the ordering clinician's discretion and professional judgment, and describe supportive resources available to aid in result interpretation. Unexpected results can be very informative regarding recent medication adherence and substance use. A result is defined as unexpected if it is inconsistent with an individual's prescribed medications or self-reported medication or substance use. Unexpected results are interpreted differently based on the testing methodology that is used. If presumptive testing is utilized, the unexpected results are generally characterized as presumptive, negative, or positive, pending the completion of additional testing by another methodology, if clinically appropriate. The threshold on a presumptive test, the analytes it is designed to cross-react with, or inappropriate cross-reaction with non-target substances can trigger false results. If definitive testing is utilized, the presence or absence of a specific compound, parent drug, or metabolite can be determined, but multiple sources may be appropriate to consider in the case of unexpected positives, and various clinical factors may contribute to unexpected negatives. Let's look at the impact of testing methodology on unexpected results using an example case. We have AS, a 45-year-old female being treated for anxiety, and she is prescribed alprazolam 0.5 milligrams daily as needed. Her provider orders a point-of-care urine test with an instant cup to test for presence of prescribed alprazolam. The cup results are negative for all substances tested. This result is inconsistent with her reported dosing schedule of taking the medication daily. With the results being inconsistent with the patient's self-report, the clinician sends the sample to an outside lab for definitive testing. The definitive results showed negative findings for the parent alprazolam, presence of alpha-hydroxyalprazolam, which is the metabolite of alprazolam, at 52 nanograms per ml, and a creatinine of 32 milligrams per deciliter, which indicates a fairly dilute sample. The instant cup may not have included cross-reactivity with alpha-hydroxyalprazolam, and if so, that could have been limited by the dilute urine. Multiple guidelines recommend unexpected presumptive-based results undergo definitive testing. The clinician's decision in that example case that we just looked at to send the sample for definitive testing is supported by guidelines. The package insert of the instant cup and most point-of-care devices likely recommends confirming unexpected results with another testing method. So what if the unexpected results are from definitive testing? How does that impact interpretive considerations? Guidelines suggest review of the unexpected results with the testing laboratory. This ensures that the correct interpretation is provided considering the testing methodology employed. When definitive results do not align with patient-reported use, discussion with the testing laboratory can help to identify a possible clinical explanation for the results, if one may exist. Some substances may have a protracted elimination period based on heaviness and chronicity of use prior to cessation, resulting in a lengthier than expected or typical elimination window and positive results beyond a usual time frame. One medication may metabolize into something that is also commercially available. For example, hydrocodone metabolizes into hydromorphone. Some results may be due to dietary intake factors, such as recent consumption of poppy seeds in the case of low codeine, low morphine positives in certain scenarios. As needed or PRN dosing of medications may shorten the detection window. And low doses of medication or less concentrated urine can contribute to unexpected negative results. So these are just some of those clinical factors that might come into play. Certainly not an exhaustive list, but these are things that could be discussed with the testing laboratory to help gain some additional insight into unexpected results. Unexpected results can also be an educational tool to help support conversations with individuals who are in treatment. The illicit drug supply is unfortunately highly adulterated with things like fentanyl and xylazine, and new concerns are evolving like medetomidine. Appropriately utilized definitive testing can help demonstrate the presence of additional compounds in a specimen. For example, this individual for the report that we're looking at here may have attested to using heroin and methamphetamine and believed that that's what they used, but they may not have realized the presence of additional substances that we're seeing here. They could have taken a pill from another person that they thought was a prescription drug, but it was actually a counterfeit pill that didn't come from a licensed pharmacy. The possibilities can be very risky, and individuals are taking an uncalculated risk and using anything not obtained from a licensed pharmacy and prescribed for them. So findings like this for illicit or novel psychoactive substances may help explain this adulteration of the illicit drug supply to individuals in treatment in showing the additional substances that were detected in their specimen. Unexpected results can also indicate other aberrant behaviors. Aegis Biodetect analysis helps identify substituted specimens through the absence of unique biomarkers that are expected in routinely analyzed human urine. With this additional clinical indicator on this example report that we're looking at here, the absence of the prescribed oxycodone can be more clearly understood as we're realizing that this specimen is not consistent with human urine. So that helps explain why the prescribed medication is not present. Unexpected toxicology results can also help inform the risk assessment process. If explanations for unexpected results based on the methodology or based on some of these clinical factors that we've been talking about, if all of that can be ruled out, then patient behavior may be the contributing factor, whether that's non-adherence, diversion, or whatever the case may be. Risk assessment helps bring objective measures for making treatment decisions, including when and what substances to consider for toxicology testing. There may be many risk assessment tools that are out there. There's many options available to practitioners, and these sorts of assessments are helpful for both the initial screening and the ongoing monitoring of a person as their risk level can change over time. The guidelines do not recommend a single tool, but they do encourage utilization of one or more of these tools. They also caution that the sensitivity and specificity of the tool should not be overestimated, as the risk assessment process is still partially subjective. As I mentioned, there are many risk assessment options to choose from. The listing here is not an indication of preference or a suggestion of what to use by any means. I'm just listing a few of the more commonly known assessments. As you can see with this image of the opioid risk tool, again, just as an example, these are generally simple assessments with objective yes/no type statements designed to help calculate a risk score based on a cumulative history of key facts about the person or the presence of certain behaviors. Risk assessment tools can help inform next steps from baseline or as risk is reassessed on an ongoing basis over time. The results can help determine if an individual is a safe candidate for chronic opioid therapy in a pain management setting, for example. They can help inform decisions about testing frequency going forward. As risk is reassessed, the results may cause adjustments to the patient's risk status or risk stratification over time. Unexpected results in a substance use disorder treatment setting can help indicate relapse or reuse, and that can help move a person to a higher risk bracket or category as a result. Clinicians can decide what low, medium, and high risk looks like for their particular population, but these objective tools can help place individuals into these categories and then adjust their placement in these categories over time. The possible next steps after an individual has unexpected toxicology findings are up to the clinical discretion of the provider. It is recommended to consult the state medical board as part of developing a protocol to see if there is any state specific guidance for the particular practice environment on handling unexpected results, and if any next steps such as referrals or prescribing decisions are expected based on state requirements. Multiple guidelines do recommend discussing results with individuals with a positive and supportive approach. One unexpected result is not intended to be the basis for changes to prescribed medications. Clinicians are recommended to discuss unexpected results with the testing laboratory, as we've talked about, or if it's a presumptive testing tool, refer to that package insert. Again, as we mentioned, that package insert may recommend confirming unexpected presumptive-based results with another testing methodology. Clinicians should document results and related clinical decisions in the patient's medical record. And as we mentioned regarding possible influence on risk assessment, the clinician may consider adjustments to future testing plans as clinically appropriate, whether that is adjustment of the testing frequency or incorporating an alternative specimen type for a future sample collection. For example, if the testing history has included a urine sample with perhaps questionable validity, that may necessitate or the consideration of oral fluid for a future testing opportunity. Testing decisions must be made in accordance with the determination of medical necessity, which is defined as providing healthcare services that are reasonable and necessary for the diagnosis or treatment of illness or to improve the functioning of a malformed body member. Providers may order testing that they determine to be medically necessary, giving due consideration to applicable medical policy coverage criteria, and providers must make their ordering decisions based upon their professional judgment as to what level of care is medically necessary and appropriate, with the understanding that some testing may lack coverage and result in higher or lower patient costs. Palmetto GBA is the Medicare Administrative Contractor, or MAC, with jurisdiction over AEGIS. Palmetto's guidance as to the appropriate frequency of testing depends on the type of treatment the patient is undergoing and the individualized patient needs, all of which must be supported within the medical record. While there is no national coverage determination concerning definitive drug testing, most of the MACs across the country have adopted local coverage determinations, or LCDs, modeled after Palmetto GBA's LCD. And there's a couple of examples here we'll talk about. Palmetto provides some guidance regarding frequency of definitive testing for substance use disorders, depending on substance-specific use history and when accurate and reliable results are necessary to integrate treatment decision and clinical assessment. Based on the duration of abstinence, more or less frequent testing may be appropriate. For example, individuals abstinent less than 30 consecutive days may have more frequent monitoring needs, whereas individuals with a longer period of abstinence may warrant less frequent monitoring. Palmetto also provides recommendations for monitoring patients on chronic opioid or other controlled medication therapy. The frequency of testing must be based on the patient's risk potential for abuse and diversion using a validated risk assessment tool. Baseline testing can also be helpful in the initial risk stratification process, and the inclusion of specific substances in testing may be dependent on patient-specific circumstances. Beyond the initial baseline, additional monitoring may be reasonable and necessary based upon patient history, clinical assessment, presence of medication side effects or lack of efficacy, suspicious behaviors, self-escalation of dose, signs of doctor shopping, indications of illegal drug use, evidence of diversion, or other clinical documented change in affect or behavioral pattern. Lower risk patients may warrant less frequent monitoring, whereas higher risk patients may need more frequent monitoring to help support safe prescribing. There are a number of resources to help clinicians with result interpretation and determination of whether results are unexpected after considering relevant clinical factors. The Aegis clinical team is available to assist clinicians with result interpretation. We are a team of PharmD or PhD credentialed individuals who routinely discuss results with all types of clinicians involved in the treatment of individuals with substance use disorder, chronic pain, behavioral health diagnoses, and other specialties. Our team provides a number of written and audiovisual resources on our website. You can go to aegislabs.com and click on the clinical resources drop down. There's a library of clinical updates and recorded webinars, and we also have a downloadable clinical reference guide that's available. Also recall that there may be special considerations with presumptive tests, so the device manufacturer may be contacted if the package insert does not have the needed information on cross-reactivity, potential causes of presumptive positives, or recommendations on additional testing. If you have additional questions about today's webinar content or other result interpretation questions, please contact our clinical team via phone or email with the information on your screen. We are available to help with explanation of pharmacokinetic and pharmacodynamic factors that could be impacting results, individualized responses to questions related to unexpected findings, and information to assist practitioners in making informed treatment decisions. I want to thank you for your time and thank you for joining us today, and this concludes today's webinar. Have a great day.